Mr. Betts, and it's an honour to serve under your chairmanship. Let me start by saying I wish to make a statement on the recent publication of the Health and Social Care Committee's report on black maternal health. Today I speak on behalf of the committee, who I would like to formally thank for all their hard work and dedication to this inquiry. And I also wish to speak for the black mothers whose lives have been forever changed by failings in maternity health care. Although I do note that many of the issues raised with the committee affect all women who use maternity services, I would also like to thank all those who gave evidence, written or oral, to this inquiry and extend my deepest sympathies to anyone affected by maternal health failings. The voices of black women are at the heart of this report, and I would like to thank them in particular for their powerful and often painful testimonies. Despite repeated policy commitments and public concerns from multiple governments, black patients still receive poorer quality maternity care and support. The support they do receive often fails to meet their emotional and cultural needs. This has led to black mothers in England being more than twice as likely to die during childcare than white mothers. In 2014 to 16, this figure was almost 5 times higher, which appears to show progress in this area. But I must stress this reduction is partly due to worsening outcomes for other groups, not improvements for black women. Our report follows a comprehensive inquiry that identified 4 key areas where action is urgently needed. The first area is culture, leadership and racism. Racism is one of the core drivers of poor maternal health care for black women. Therefore, it must be tackled urgently and effectively. Black women suffer from stereotyping, bias and racist assumptions during childbirth. This was made explicitly clear to us at the committee throughout the inquiry. The testimonies we heard were harrowing. Let me share some examples. Firstly, women suffering from the strong black woman trope. During active labour, one woman was denied pain relief and given only paracetamol. A baby was born 10 minutes later. Another woman told us she could handle the pain despite losing a concerning amount of blood. We also heard a midwife choose to blame an African pelvis for slow labour rather than check for complications. Another mother was told she was making noise when she pleaded for help during childbirth, ignored by staff. Another experienced racism in its purest form, being told, "This isn't Africa, you know," when she had family members visiting. We also heard of a black woman receiving no breastfeeding help or support from white midwives. This only changed when a black student midwife came on shift. A report from the organisation X5, 5X should I say, 5X More, describes similar experiences. I would also like to note that racism in the NHS doesn't only harm patients, it affects healthcare professionals from minority ethnic backgrounds too, as they encounter and experience the same discriminations and structural barriers, just in a different context. This, alongside the host of other evidence we received, led us to call for mandatory cultural competency and anti-racism training in the NHS, as currently where this does exist, it's optional or limited in scope. We also call for leadership to be held accountable for creating inclusive and anti-racist environments. As we have heard, that NHS Trust can refuse to even acknowledge racism exists in their services. When we spoke to the Minister, Baroness Mirren, she agreed that greater accountability is needed. This is welcome, and we will continue to hold her and the wider government to account on this issue. The second key area for improvement is the workforce. The NHS currently faces a shortfall of 2,500 midwives. On top of this, 74% of midwives cite unrealistic workloads and 87% report unsafe staffing levels. These shortages directly impact the quality and continuity of care that all mothers receive. It is essential that in the upcoming workforce plan, there are firm commitments to deliver safe staffing levels for maternity services. We also know the importance of having continuity of care for midwives and mothers, building trust, tailoring support, and spotting warning signs early. This used to be a national target, but was abandoned 3 years ago due to workforce pressures. We call for this target to be reinstated in the upcoming plan. Workforce diversity is also paramount. We've heard that despite being almost a third of the workforce, only 12.7% of senior NHS managers are from minority ethnic backgrounds, and 95% of midwife educators are white. The plan must therefore include specific targets to diversify maternity leadership and education, backed by robust monitoring. The third area is data. Without complete data, disparities in maternal outcome cannot be accurately identified, let alone improved. This is particularly relevant in two areas. Firstly, maternal morbidity. Currently, frameworks for monitoring maternal morbidity do not meet the same scope or rigour of baby deaths or maternal mortality. Repeated governments have discussed implementing a maternal morbidity indicator to track and measure non-fatal complications such as sepsis, eclampsia, and postpartum hemorrhage. But progress has been shockingly slow. Developments must be accelerated on this measure with a clear timetable for implementation. Secondly, data on ethnicity. Too many ethnicity entries in the maternity services data set are recorded as unknown or not stated. In one 2022 example from Shrewsbury and Telford hospitals, over 9,000 missing ethnicity background details were identified. Better data is crucial to improving results for those with the lowest outcomes in maternity health, Black women. The upcoming workforce plan must also include support and training for effective data collection. The final area I would like to discuss is funding. All the issues related to maternity care that I have spoken about today simply cannot be fixed without adequate funding. Yet the Maternity Service Development Fund has recently been cut from £95 to £2 million. This is deeply concerning. While the NHS said the money is still available, it's just been removed elsewhere in the budget. We are concerned that without ring-fence funding, maternity services will be deprioritised and continue to cause harm for all mothers. We therefore call on the government to restore the dedicated ring-fence funding for the Service Development Fund to its previous amount. Since 2019, the NHS has faced £27.7 billion in bills for maternity negligence. This exceeds the total maternity budget for the same period by almost £10 billion. I know that there are funding pressures across the NHS, but this clearly shows that greater investment here would have the potential to more than pay for itself. Since we launched the inquiry, the government has announced a rapid national investigation into maternity and neonatal services. This is welcome. In this work, addressing the racial disparities in maternal outcomes must be one of the core aims of the investigation. I hope to see this as a prominent feature in the investigators' work.